kind introduction. And I think it's a great, exciting session which has brought out so many useful findings and so many useful insights. And it is, I think, all about mutual learning from each other, because all of us, like COVID, are also in different stages of banking. Somewhere it has picked up, and somewhere it has not as much as it should pick up. And so it helps to mutually it helps in mutual learning with each other. So I would be talking about iBanking and iBanking alternatives in the COVID-19 era. And for us, this was a revelation. Just before the COVID, this came out that in our country, corneal opacity is the second commonest cause of blindness after cataract. It used to remain the fourth, and from fourth, it has now jumped to second. Uh, there are 1 million bilateral blind and 6.8 million people who have visual acuity less than 6 by 60, and curable by keratoplasty is about 10%. New patients per year added are 40 to 50,000 blind patients, and blindness primarily due to cornea. Now, as soon as the COVID came up, there was advisory from the government of India to stop the eye banking completely. And so we came out with guidelines for cornea and eye banking in the COVID era. And this uh, guidelines from All India Ophthalmological Society not only had the guidelines for cornea and eye banking, but had in each and every subspecialty. And so this was almost 104 pages document. And as far as the cornea and eye banking is concerned, we collaborated with the Ministry of Health and Family Welfare, because we wanted them to understand that eye banking has been hit. And of course, All India Ophthalmological Society, the Cornea Society of India, and the Indian Society for Cornea and Keratorefractive Surgeons, and all these were done on discussions in the various Zoom meetings. So we came out with version 1 on 11th May when lockdown was announced in our country, then version 2 on 1st September 2020, and then version 3 on 5th October 2020. And this was also published in the Indian Journal of Ophthalmology after a consensus document was made. Now, it was not made mandatory to collect the nasal swab of the deceased donor for RT-PCR. It was left to the medical director, but it was emphasized that technicians and the relevant staff should be given training about PPE, and one has to follow the local THOTA, NOTO, SOTO, ROTO, or state health authority or NPCB for daily or weekly reports. And the IBanks, because in our country health is a state subject and each state governs it separately and has a different set of rules, so one has to follow the local state government rules. Exclude criteria for ocular tissue collection where they were tested for COVID positive, or if there was any suggestion thereof in the form of fever or acute respiratory illness or evidence of conjunctivitis or ARDS or ground glass opacities on the X-ray. Now, the algorithm that we followed was this: that if the deceased donor was there in the hospital and it was a confirmed case of COVID, or exposed to a confirmed case of COVID, or has lived in or visited any affected part within the previous 28 days, then you have to assess the clinical situation. And if it is compatible with COVID-19, then no donation. But if there are no symptoms compatible with COVID-19 and screening for COVID-19 has been done and it is positive, then of course there is no donation. But if it is negative, then you can proceed with donation. And very safe cases were only taken for eye banking with no epidemiological risk and no evidence clinically thereof. So, general functioning guidelines were as was there for the entire ophthalmological practice, which included relevant history taking. And we do enucleate eyeballs also in some parts of the country, almost to the tune of 40%. So, we recommended that only corneoscleral rim excision be taken and avoid the whole eyeball enucleation. Then use intermediate preservative media, because in our part of the world, a lot of MK media is still being used. The eyes which were not used at that time were all shifted to glycerol to prolong their life, so that at least they could be used for therapeutic purposes. And recovery procedures mandatorily require double contact of povidone iodine to ocular tissue before retrieval. Then all the donor forms and documents to be exposed to UV light immediately after the team arrives at the eye bank. The technicians who handled tissues and materials had to follow strict COVID appropriate behavior, and also the eye donation counselors. who were on call and were not placed at the site. Then of course frequent hand washing, mask which was mandatory, and social distancing, as well as staff training in all the eye banks was done. And this is from Eye Bank Society of Rajasthan. Some of the pictures, and from Shroff Charity Eye Hospital, where Dr. Manisha Acharya is the medical director who's with us today. And we also did a survey and also looked at our data, and we found that the collection of the eyes had gone down by almost 78 to 80% in March to May 2020, and this was during the lockdown. And our tissue distribution also was decreased by 82%. The corneas collected, when we compared with 2020 and 2019 in the same era, there was a marked decrease in the corneas which were collected. 93% drop in the number of transplants in the last 4 months, that is April, May, June, July, when we compare it with the previous years. And only this was a survey that we conducted, and only 50% said that they would get back to normal, and it'll take 6 months or more than 6 months. But now I think we are almost a year and we've still not gotten back to normal. Most people had shifted from MK Media to Cornisol. Cornisol is something like Optisol, only it is made in India, and so it is cheaper as compared to Optisol. And also people had started using glycerine and glycerol, which earlier it was not being used. And transplant surgeries had markedly gone down because we were only told to do therapeutic keratoplasty and not elective surgeries. Special eye training to eye bank staff before restarting the operations was done by 80% of the eye banks. Voluntary attrition of the staff also occurred due to COVID because some people didn't want to do these duties. This was to the tune of 7.3%. Of course, whenever COVID positive donors were there, no eye bank took those eyes. Nasal swab testing, although the eye bankers felt that it should be done for all donors to the tune of 40%, but almost 40% were not doing it. And surgery only for COVID 19 test report of the recipient again, although similar percent, 40% felt that it should be done, but 37% were still doing without this test. Teleconsultation or teleophthalmology had increased drastically to the tune of almost 70%. And then in these times when we did not have the tissue, there were a lot of other alternatives were looked into, like glycerine preserved cornea, sclera, tissue adhesives, conjunctival hood, tasso-raffi, Teenan's patch graft, etc. So
U-tool assessment of
this
corneal ulcer
was
via
a U
teleconsultation.
tool that was devised because the patients of corneal ulcer, they could not follow up with us. So this was devised in our casualty by our senior resident, Dr. Rahul Bafna. So these are just Sherma strips which are being taken, and this U tool device was made so that patients didn't have to, come to follow up, and they could probably do this at home only. This is being done in our casualty services. So if you take a smartphone and you click a picture of this, and these pictures were then sent to us. And of course in a hospital you can do it with a fluorescein staining also. And in children it was really helpful because the parents would take these pictures, and we could follow up fate of corneal ulcers using this. So this was one of the innovation which was done at our center during this time. Then there were lack of tissue, so we did use other kind of tissue like Teenan's patch, and these are some of the cases which actually required cornea, but Teenan's graft was used because it was readily available from the patient's own eyes without having any rejection, since it was autologous. And these are some of the pictures of Teenan's patch graft to suture the corneal perforations. Then we did a lot of conjunctival flaps as well, also because because the corneas were not available. Then amniotic membrane transplantations were also done from the amniotic membranes which were previously available to us. And this is the to show how Teenan's patch graft it helps, although for corneal perforations there are a lot of alternatives which are available, which include your glue, cyanoacrylate glue. Then it includes your conjunctival flaps, then your amniotic membrane transplants. But we thought Teenan's is a good idea, and this was described almost 4 years ago by us, because the Teenan's capsule has a fibrous capsule in it, and that helps in the fibrosis if you look at the histopathology. So these small perforations also could be dealt with the Teenan's. And the important thing is that you just debride the necrotic epithelium and even make a small tunnel sort of a thing where the tenons can be tucked in. Now, this tenons is readily available in the patient's own eye, and this is dissected. And it's a very flimsy tissue, so you can just make it like a pillow and tuck it inside the pocket which was previously created, and then apply glue on it. And if it is a larger one, then we can even apply sutures on it. And this is followed by the glue which is applied on from all sides. Fibrin glue can be applied, even cyanoacrylate glue can be applied, and then bandage contact lens following this. This is another case of perforation which was managed by Teenan's patch graft. And these cases do look good, and over a period of time there is fibrosis, but for paracentral perforations they do well. And this fibrotic or fibrosis of the corneal haze also clears up over a period of time. It doesn't clear up completely, but it does fade away, and this is follow up 1 year, and the AC is formed in the post operative period. Now, it can be obtained from the patient's own eye, so you don't need an eye bank for it. You don't need the expensive features that you require for amniotic membrane, a lab to procure it or harvest it. It can be sutured, as is shown here also. It can be sutured using suture. It could be 10-0 monofilament nylon suture, which can be used to suture it. And then after doing it, one can form the anterior chamber also. And we have described this in our review article as well, which is published in Survey of Ophthalmology, that there are so many things which are available, but tenons is yet another thing which can be added to our armamentarium in the event that you don't have a corneal tissue available, which is a reality in our part of the world, which may happen. And we use this during the pandemic as well. So there are no rejections because it's the patient's own tissue. So that is yet another benefit from it. People did use glycerol preserved corneas also, and this is a report, wonderful report by Dr. Neeti Gupta from AIMS Rishikesh, where they've used glycerol preserved corneal tissue in emergency corneal transplantation because the corneal tissue was not available. Then people have even used fresh sclera and also multi-layered Gore-Tex for corneal perforations. So these can be some of the alternatives, and God forbid if we have another pandemic or any other exigency likewise, then these are the things which we can look at. So in the COVID times, iBanking has taken a major hit, and it was in December only that HCRP program and the voluntary eye donation both were allowed. Prior to this, it was not allowed, and so now it has started picking up. And alternatives of corneal tissue are here to stay even in the post-COVID times, especially in those places. And these can be used as an interim procedure where these are where corneal tissue is not available. So thank you very much for your kind attention.